All right. Hi, everybody. I hope everybody's having a great afternoon. My name is Adrian Garces, and I'm a third-year master's student in the lab of Dr. David Grosshans here at the University of Texas MD Anderson UT Health Graduate School of Biomedical Sciences. And today I'm here to talk to you about the effects of combining radiotherapy and the inhibitor ivosidenib of IDH1R132H in glioma stem cells. So just to give a brief introduction, gliomas are cancers of glia, which are cells that support axon synaptic activity in both the central and the peripheral nervous systems. You can see right here, there are 6 different types of neuroglia. However, we're going to be focused in mainly on oligodendrocytes and astrocytes because those are the most common forms of gliomas, astrocytomas, and oligodendrogliomas, astrocytomas being the most common. In the United States, there are about 80,000 new primary brain cancer diagnoses every year, with 25% of them being malignant glioma. And of those 25%, 15% of them are glioblastoma, which is the most malignant form of glioma. Now, really quick, I want to talk a little bit about the clinical classification of gliomas. We have, starting at grade 1, which is the most benign form of tumor. This tends to be a more localized tumor and can be generally treated with just safe growth surgical resection. However, as you can see, as you go from grade 2 to grade 3 and even to grade 4, otherwise known as glioblastoma multiforme, not only does the mean patient age go up, the aggression also goes up and the dispersity increases as well. The tumors tend to get more diffuse as you go up through the grades, and a combination of surgery, radiation, and chemotherapy is often required, especially in the grade 3 and grade 4 tumors. Something that I did want to mention actually though is the difference between the primary and the secondary GBMs. So primary GBMs, you can see right here, the survival time is extremely low, about 15 months. And the reason why that is because primary GBMs develop de novo. There's no precursor cells to the tumor. The patient just presents with a glioblastoma. That is what's known as a primary GBM. A secondary GBM actually does a malignant transformation from grade 2, grade 3, and all the way up to grade 4. Essentially, they start at a lower grade and transform into a glioblastoma. And the difference in survival time isn't stark. However, overall, less than 5% of these patients live past 5 years. So therefore, there is a very, very high need for novel treatments for this patient population. Additionally, the World Health Organization, in addition to histopathological guidelines, in 2016, they added the use of genetic alterations as well to diagnose gliomas, specifically the use of mutant IDH, alpha thalassemia retardation X-linked syndrome, loss of function, which we'll talk a little bit about later, as well as the chromosome 1p19q co-deletion. So essentially, the astrocytomas can exist in either a wild type or a mutant IDH flavor. A lot of times you see these mutant IDH astrocytomas, they can present with both mutant IDH and ATRXLoss. However, oligodendrogliomas, they present with mutant IDH and 1p19q co-deletion. As you can see, this actually does have a stark impact on the mean overall survival of the patients, with the oligodendroglioma patients tending to survive longer than those of astrocytomas. Just another graph right here. I just wanted to highlight the rationale why we need to increase the research into novel treatments, especially for astrocytomas and oligodendrogliomas. Over the past several years, there's a study done by Klaus et al. In 2015 that essentially surveyed from 1973 all the way to 2011 the survival of patients with astrocytomas and oligodendrogliomas, and there really hasn't been too much of a difference in that time. Now I'd be interested to see the results up to 2020. However, you can see right here that there really hasn't been too much of a change over the course of the past few years. So therefore, it's even more imperative to find novel treatment options that work for this patient population. So the next part of the talk, I'm going to be detailing a little bit about IDH and ATRX losses. Those are central to my project. So IDH, we're going to be talking mainly about IDH1. However, IDH, I do want to acknowledge that IDH2 and IDH3, those exist in the cytoplasm, the mitochondria. IDH1 exists primarily in the cytosol. Essentially, the normal function of the wild type IDH1 is to convert isocitrate, this molecule right here, all the way into alpha ketoglutarate, creating NADPH and carbon dioxide as byproducts. Now, in glioblastomas and lower grade gliomas, 70 to 80% of lower grade gliomas and secondary GBMs harbor the IDH1 R132H mutation. So you can see right here, this is at the catalytic site. Therefore, it has an impact on essentially what this enzyme does. So you can see right here in the mutated form, the IDH1 R132H, not only does it take isocitrate alpha ketoglutarate, it reduces the alpha ketoglutarate into 2-hydroxyglutarate, as you can see right here by a reduction of the ketone group into the alcohol group, and the oxidation of the NADPH into NADP+. Now this is very important because NADPH is a protector of reactive oxygen species, or essentially oxidative stress. So therefore, this 2-hydroxyglutarate, the creation of this molecule takes away that protection against reactive oxygen species, which tend to be induced primarily by radiation therapy. So therefore, it is implied that 2-hydroxyglutarate is a positive thing for the cell. And we see that also in the clinic as well. In the clinic, patients that present with IDH mutations tend to live a lot longer than those with wild-type IDH, as I showed in the previous slide. Now, I mentioned earlier about the 2-hydroxyglutarate. There's been various papers that have looked into the function of this 2-hydroxyglutarate since it was first discovered in 2008 by Parsons et al. Essentially, there's been several studies that have looked at the function. However, I do want to highlight 3 of them that are the most pertinent right here. So as I said before, 2-hydroxyglutarate decreases the levels of NADPH just from its creation. And so therefore it promotes the higher reactive oxygen species levels. So you can see right here, due to the, essentially NADPH, as I said before, is a protector against oxidative stress, no protection, therefore higher reactive oxygen species levels. Additionally, however, it actually has an impact on DNA damage repair, which is very, very vital for radiation-induced damage. So as you can see right here, the homologous recombination capacity of the cell is actually impaired due to the lower phosphorylation of ATM in the nucleus, you can see right here. But also we have PARP inhibitor sensitivity, as was discovered by Solkowski et al. In 2017. However, the full function of the 2-hydroxyglutarate has yet to be elucidated, as there are many reports on it right now that are, tend to be conflicting in nature. So the true nature of 2-hydroxyglutarate is still an active area of investigation. Additionally, ATRX is a very, very key area of investigation. So ATRX, as I mentioned, is an alpha thalassemia retardation X-linked protein. So essentially, this protein is a chromatin remodeling protein that recruits the death-associated protein DAX, which then goes on to recruit histone 3.3s to deposit them at either telomeres or pericentromeric heterochromatin. There isn't too many studies on ATRX null cells. However, one of them, the key one of which I want to reference, is Koshman et al. In 2016, looked at glioblastoma, and they found that ATRXLoss has been linked with impaired non-homologous end joining capacity, as well as increased capacity for alternative lengthening of telomeres, that phenotype, that ALT phenotype. However, this is still very much an active area of investigation, and one that I want to, kind of bridge the knowledge of IDH mutations along with ATRX loss of function. Now, getting into the core of my project, so I study cancer stem cells. And so as I was mentioning earlier, glioblastomas, they're dispersed tumors. However, within that tumor, there's different subpopulations of cells, and one of which are these cancer stem cells. These cancer stem cells are very similar to normal stem cells. They're undifferentiated, and they help initiate the tumor, and they're one of the #1 causes of tumor recurrence in the clinic. Reason why is that they're extremely chemoradiation-resistant, also resistant to the effects of the immune system, and differentiable, so that they can change into different cells within the tumor, and cells can also de-differentiate into cancer stem cells, making them very difficult to find and treat. So as I mentioned earlier, they are responsible for tumor genesis, vasculogenesis, as well as inflation and metastasis, ultimately tumor recurrence. Therefore, it's very, very imperative to not only treat the tumor itself, but the stem cells, the cancer stem cells. And one of the ways we're doing this is through radiation therapy. And I study X-rays as well as proton therapy. So proton therapy versus X-ray therapy, I just want to highlight the differences between the two. First of all, X-ray therapy is conventionally what you would receive in the clinic. Protons are mainly reserved for head and neck cancers. So photons, essentially what happens, just a little bit of a physics lesson, X-rays, when they enter your body, they enter at the maximum dose. So what that means is that when they enter the body, enter the skin, they deposit their maximum dose and they just keep going down and down until you hit the target. Not so with protons. Protons are special because they're small particles. They're particles with mass. And so essentially they have this property called linear energy transfer. So they deposit energy as they go through your skin. But what ends up happening is due to this property, they don't deposit all their dose at once. They start with a low dose at the entry site, get to where they need to go at the target, the tumor, deposit their dose, and then have no exit dose. Essentially making sure that you have specifically that you only irradiate the tumor and not everything around the tumor, the healthy tissues. Additionally, they've been known to be associated with more clustered DNA damage compared to conventional X-ray therapy. And so my research, my project, the objectives of my project are twofold. I want to look at IDH1, R132H, and ATRXLoss on the GSC self-renewal capacity, as I'm going to talk about through the limiting dilution analysis, comparing X-rays versus protons. Secondly, I want to look at the combination of Ivosidenib, which is a IDH1 R132H inhibitor that is currently in phase 1 and phase 3 clinical trials in gliomas. I want to see what the effects of combining Ivosidenib and radiotherapy are on GSC survival. And my hypothesis is that IDH1 R132H and ATRXLoss, these will independently promote sensitivity to radiation. Comparing protons and X-rays, protons will be more sensitive, GSs will be more sensitive to protons than they are to X-rays. However, I believe that Ivosidenib is actually not beneficial to gliomas. I believe they will actually reverse the IDH1 R132H conferred radiosensitivity, as you will see in my data, by inhibiting DNA damage and promoting GSC post-radiation survival. And I've drawn a graphic right here for your reference. It's just really quick getting into the methods of how the limiting dilution analysis works before we get into the data. So essentially, the limiting dilution analysis assay is a way to measure GSC, glioma stem cell, self-renewal capacity. So essentially what happens is you seed at different seeding densities. My densities were 20, 10, 5, and 1 cell per well. I seeded in the 96 well plate. In these experiments right here, I want to compare the difference between ATRX wild type and ATRX loss. We use isogenic TS543's ATRX loss and isogenic MGG18 IH1R132H cells. The TS543 cells were provided by Dr. Jason Hughes here at MD Anderson. The IH1R132H, the MGG18 IH1R132Hs were provided by Dr. Cahill from the Massachusetts General Hospital. These ones are activated with pyrimycin. These guys are activated by doxycycline. And so essentially, as I was saying earlier, so seeding densities. So you see at 20, 10, 5, and 1 cell per well, and then exposed to the irradiation. And after 4 days, you see which of these wells formed full-blown spheroids. And spheroids are defined as any structure with a diameter that is greater than 20 micrometers. So this method was developed by Hu and Smith et al. In 2009 and perfected by another group in 2018 that I'm using that protocol specifically for GSCs. Let's get into the data really quick. So first of all, I want to show the difference between the ATRX loss and ATRX wild type, comparing X-rays and protons. So as you can see right here, ATRX loss actually responds not as well to X-rays compared to protons. And I'm going to walk through this graph really quickly. So the y-axis is a log fraction of non-responding cells. So essentially what that means, this is the amount of cells that do not form spheroids. As you go up the y-axis, more of the wells are non-responding, as in they don't form spheroids, comparing with the dose on the x-axis, the number of cells that were seeded originally. So therefore, the slope of the line is indicative of the self-renewal capacity. If you have a slope of the line that is tending more towards zero, as in tending more towards horizontal, you have a impaired self-renewal capacity compared to a slope that is more vertical, as you can see right here. So therefore, the ATRX loss, at least with the X-ray therapy, is not as beneficial compared to the protons. So ATRX loss actually is more beneficial when you're irradiating with protons compared to with X-rays. This was done both at 3 gray and at 4 gray. The X-rays were done at using an XRAD 320, and the protons were done at the MD Anderson Cancer Center, Proton Therapy Center. And so right now I just want to really compare the differences between the protons and the X-rays. Right here I have a table of the self-renewal, or sorry, the neurosphere formation frequency of all of these cell lines that were treated with either X-rays or protons. So the lower and the upper, this is the 95% confidence interval. And the estimate right here is like I said, it's a spheroid formation frequency. So for example, this 1/2 right here, that means that cells irradiated with this condition, the ATRX loss irradiated with X-rays, after the spheroids are allowed to form, 1 and 2 of the wells form full-blown spheroids. Therefore, the treatment is not as effective. We want this number to be as low as possible, as in we want the denominator to be as high as possible. The fold reduction is comparing this number, the estimate, to that same cell line, but with no treatment, as in 0 gray radiation. So as you can see right here, the wild type, for your TS543 ATRX losses, proton therapy is significantly more effective than X-ray therapy. As you can see right here, this is the red line comparing with the black line. And as you can, and also you can see that in the fold reduction at both 3 gray and at 4 gray. Now, IDH1R132H was also associated, it also had the same trend. Again, we're going to be showing 3 and 4 gray data, XRAD comparing to the protons. So we see the same trend, IDH1R132H irradiated with X-rays, not so beneficial. However, with proton therapy, you see it's an opposite story. And it's done both at 3 gray and at 4 gray. To highlight the trend right here, the trend was a little bit interesting for the IDH was, we can see that there's a significant difference in protons compared to X-rays with IDH1 wild type. You can see the green line compared to the blue line right here, that essentially if you have a wild type IDH1, the best thing to do is to irradiate with X-rays. But there wasn't so much of a difference between the protons and the X-rays for the IDH1R132H condition, which we found fairly interesting. And you can see it also reflected in the spheroid formation frequency and fold reduction compared to 0 gray. Now, then the last part of my experiments, as I mentioned earlier, I wanted to do an experiment where I combined Ivosidenib with radiation therapy. And so I want to basically describe the rationale behind that experimental design. So there's a paper done by Molinar et al. In 2015 that actually looked at essentially the first generation of the Ivosidenib, this AG5198 molecule. Ivosidenib is essentially the second generation of this IDH inhibitor. And they combined this with X-ray therapy and measured reactive oxygen species levels. As you can see right here, this was done in a colon cancer cell line as well as in a glioblastoma cell line, the U251s. As you can see right here, first panel, AG5198 XRT, it actually decreases the reactive oxygen species levels, increasing NADPH and GSH. You can see right here in this cycle of production of reactive oxygen species, increasing glutathione and NADPH actually impairs the production of hydrogen peroxide. And this also I found interesting, in glioblastoma cells, the clonogenic fraction actually increases as you combine radiation with the inhibitor. However, if you add 2-hydroxyglutarate to cells that were previously treated with X-rays and AG5198, it actually the trend reverses. You can actually salvage the radiosensitivity that was originally put forth by the IDH mutation to start with. Therefore, 2-hydroxyglutarate really is a key factor in this radiosensitivity. And the same thing was found in terms of DNA damage. You can see right here that in this plot that combining the inhibitors with X-ray radiation actually decreases the frequency of gamma H2AX, which is a known indicator of double-stranded DNA damage. What am I trying to say here? So I actually recapitulated this trend in my GSCs. So I used the MGG18 IDH1R132H. These are the isogenic cell line that I was using earlier. And so we see right here from my graph that combining the combination of ivosidenib 5 nanomolars with 5 gray of X-ray therapy actually is not beneficial if you just have the IDH1R132H mutation. So you can see right here the shift in the curve towards the vertical indicates that the spheroid formation frequency actually increases with this treatment compared to the X-rays alone. And you can see that also at 6 gray, the X-rays alone were better than the ivosidenib alone, and the combination therapy was worse than the X-ray therapy. Essentially, the X-ray therapy alone was the best course of action for cells that just had the IDH1R132H mutation. Finally, I actually used the final cell line that I used was GS818. And so this cell line harbors ATRXLoss and IDH1R132H, the same genetic profile as astrocytoma patients present with. And the opposite was actually the result. I'm sorry, wrong slide. So for 4 gray and 5 nanomolars of ivosidenib, we actually saw that the combination treatment of X-rays and ivosidenib was the most effective out of the monotherapies. So essentially the combination of the ivosidenib X-rays was more effective than the ivosidenib alone. And so was the X-rays as well, as you can see down here. And this was done at both 4 gray and at 6 gray. So therefore, this implies that ATRXLoss is essentially required for that radiosensitivity. Not only is IDH1R132 required for that radiosensitivity, but ATRXLoss is also a key player in that radiosensitivity for GSCs. So my conclusions is that these both independently inhibit self-renewal for protons. However, when you combine ivosidenib and X-rays, you really need to have that IDH1R132H and ATRXLoss profile to really see any benefits. You actually have the opposite effect in the IDH1R132H cells alone. For the future directions, I want to look at the GSC self-renewal capacity in the protons combining with ivosidenib as well as vorasidenib, which is a pan-mutant IDH1 and IDH2 inhibitor. And it was just developed this year, actually. So I want to take a look at that in combination with protons. DNA damage repair capacity, looking at specifically the foci of gamma H2AX and 52PV1 through an immunostain, comparing the X-rays along with the combination therapy. And finally, taking a look at apoptosis and necrosis to look at a more mechanistic view of the study. And so finally, I want to acknowledge my mentor, Dr. David Grosshans, has been instrumental help in developing this project and guiding me through every step of the way through my master's. All of my lab members, I want to thank all of them as well, especially Lawrence. Lawrence is a very big help to me in the lab, great mentor as well. Also, I want to acknowledge Wei, Diathan, Ria, Tuba, and Enos. Sawaguchi lab, Gabriel Sawaguchi's lab, especially I want to highlight Scott, David, and Connor for their help with the irradiations. And finally, I want to acknowledge my advisory committee, which has also been a great help in this project, instrumental in my mentorship, specifically Krishna Bhatt, but also especially Fada Guan, Stephen Lin, and as I mentioned earlier, Gabriel Sawaguchi. So thank you all so much for taking the time out of your day to listen to this talk, and I'll take any questions right now, either in the chat or through live.